Okay. So, hi everyone. Welcome to the February History Research Rounds. I see lots of familiar faces, especially in the conference room where my peeps are. And for those who I haven't met, my name is Shelley Wei, and I'm the lead analyst at ICS Queens. So unfortunately, Catherine is not able to join us today, so it's my pleasure to get our research round started. I want to start today by recognizing that those of us attending from the Kingston area are situated on the traditional Anishinaabe and Haudenosaunee territory, and we're very grateful to be able to live, learn, and play on these lands. And thank each of you for taking the time over the next hour to be present as we consider how our research at History can help support principles of equity, diversity, and inclusion. And today, as we listen to Dr. Flemming on how these principles can be applied to our understanding of how we support those people living with chronic health conditions, and specifically those most at risk. So I'm very pleased to introduce Dr. Jennifer Flemming, who is an associate professor of medicine and public health sciences at Queen's University with clinical training in gastroenterology, hepatology, and liver transplantation. She is also a ICS adjunct scientist and our site director of ICS Queens. Dr. Flemming is a clinician scientist who leads a research program which leverages Ontario administrative data housed here at ICS to evaluate the epidemiology and outcomes of patients with cirrhosis. I'm excited to hear your research in harmful alcohol use and associated liver outcomes in young adults in Ontario. So Jen, I hand over the floor to you.
Great, thanks, Shelley. I'm just going to share my screen here. Okay, everybody can see that okay? Okay, I'm just going to hide people's faces so I can look here. So thanks for the introduction, and thanks again for History for asking me to present today. And this is going to be kind of on a similar theme as the last time I presented. So last time I presented on alcohol harms among women. And today I'm going to be more focusing on a different vulnerable population, which are adolescents and young adults. Oh, sorry, my clicker here is not, okay. No conflicts of interest for this. So over the next 45 minutes or so, I've divided the talk up into 5 different sections. So the first section, I'll be talking about alcohol-associated liver disease terminology as well as epidemiology. Then we'll discuss effects of alcohol in the liver and the clinical spectrum of alcohol-associated liver disease. We'll briefly touch on the treatment of this condition, and then we'll focus on some of the work that we've been doing here with History and ICES on alcohol-associated hepatitis among adolescents and young adults in Ontario. And we'll end with discussing some health policy implications of these data. So first, we're going to talk about the epidemiology and terminology of alcohol-associated liver disease. So as most people on this call are aware, alcohol is associated with many adverse health effects. The WHO has identified that alcohol misuse is a leading cause globally of morbidity or mortality and is attributed to 3 million deaths annually across the world, in addition to substantial morbidity. Of most concern, it's actually the leading cause of premature mortality and disability in our younger population aged 15 to 49. And disadvantaged and vulnerable populations carry the highest burden of alcohol-associated death as well as hospitalization. So I want to make sure that the audience understands that these two conditions are distinct but related. So I'm going to be talking about high-risk drinking, and I'm also going to be talking about alcohol use disorder. So when we talk about high-risk drinking is defined based on the quantity of alcohol, which is associated with alcohol-associated liver disease. And you determine whether or not somebody is at high risk based on the history from either the patient or the caregivers. Now, the quantity that puts people at risk of alcohol-associated liver disease differs between males and females. And among males, it's thought that greater than 30 grams of alcohol per day or more than 210 grams per week puts people at risk. Whereas in females, the level is lower, greater than 20 grams per day or greater than 140 grams per week. And I'm going to be talking about this a bit later on in the talk as well, but when we try and quantify alcohol, we use the terminology of one standard drink. And in Canada and the United Kingdom, one standard drink is considered 10 grams of alcohol. And I'll go through this a little bit later on as well. The reason why there are these differences in recommendations for alcohol use between men and women are because we know that there's sex differences in alcohol metabolism. We know that among women, they have approximately 30% less alcohol dehydrogenase, which is secreted into the stomach compared to men. Women also have lower body water, which can increase the concentration of alcohol for the same content. The liver is a sex hormone responsive organ, and so the effects of sex hormones such as estrogen come into play. And it's also been shown that there are differences within the microbiome between males and females who have alcohol-associated liver disease, which is also implicated in the pathogenesis. So high-risk drinking is in contrast to alcohol use disorder, whereas alcohol use disorders does not use a quantity of alcohol, but it's defined based on the behaviors and the consequences of alcohol use. And it's a diagnosis that you make based on DSM-5 criteria, based on the presence of 2 or more of these criteria over the past year. And it can be defined as being either mild, moderate, or severe alcohol use disorder. If you are a clinician and spending time with patients in the clinical setting as well as the research setting, we use the audit tool, the Alcohol Users Disorders Identification Test, to try and screen people for underlying alcohol use disorder. And what I really want to try and highlight here is that there is a big overlap among people who have both alcohol-associated liver disease and alcohol use disorder. But I also want to make sure that people understand that among individuals who have alcohol-associated liver disease, not all of them have alcohol use disorder. And among individuals who have alcohol use disorder, not all of them have alcohol-associated liver disease. So I'm going to spend a few minutes now just reminding the audience about the epidemiology of alcohol use in our Canadian population. And this is data from the Canadian Community Health Survey. The most recent update was in 2017. And we can see that past year, any alcohol use within our population is almost 80%. And this can vary by province. So we see that the lowest proportion of individuals using alcohol annually are in Prince Edward Island, whereas the highest proportion reside in the province of Quebec. There is also differences by age. This graph looks at the proportion of any alcohol use in the past year based on your age. And we can see that it's highest among individuals aged 25 to 34 at 87%. Similarly, there's differences based on sex and gender. Traditionally, males have always been higher users of alcohol. However, over the past decade, females are now reporting alcohol consumption almost similar to men. So you can see here at the bottom, in 2013, 81% of males used alcohol in the past year versus 71% of females. But by 2017, that had already changed, where males, the proportion was stable, and among females, it was 77%. The Community Health Survey was also able to look at high-risk drinking. So these are individuals, males drinking more than 30 grams per day, females more than 20 grams per day. So these are the proportion of our population who would be at risk of alcohol-associated liver disease, and this is about 20%. And again, if you break that down based on age, we can see here that younger individuals are more likely to participate in high-risk drinking. And again, some interesting trends that have been occurring in our population are that high-risk drinking among males decreased by 10% over a 10-year period. However, it increased by 30% among females. So taken together, based on these data, approximately 75% of our population has used alcohol at any point in time in the past year, and 20% of the population participates in high-risk drinking, which would put them at risk of alcohol-associated liver disease. The Community Health Survey is unable to define the proportion of individuals who have underlying alcohol use disorder. But if we estimate based on proportions that have been reported in the United States, we suspect that approximately 5% of our population has alcohol use disorder. So there are many, many individuals within our population who are going to be at risk of developing alcohol-associated harms. And we know from lots of data that the liver is the most common end organ affected by high levels of alcohol consumption, which is why myself as a clinical hepatologist, I spend a lot of time seeing people who have the consequences of alcohol and who have underlying alcohol use disorder. I also want to highlight that the hepatology community is really trying to move away from stigmatizing language surrounding our discussions about alcohol-associated liver disease and alcohol use disorder. So you can see here on this chart that the terminology that many of you may be familiar with and that's used colloquially in our country are the terms alcoholic liver disease, etc. And so what our community is really trying to do is trying to destigmatize the language, as we know that that's part of the problem when people are trying to seek help for their underlying conditions. And so we use terms like alcohol use disorder, alcohol-related liver disease, and as I'll be talking about later on in the talk there at the very bottom, the old term that we used to use was alcoholic hepatitis, and now we're using the term alcohol-associated hepatitis. So next, we're going to move on to the clinical spectrum of alcohol-associated liver disease because it encompasses a very heterogeneous population of conditions. So first, I just wanted to touch again on how do we actually quantify alcohol? So if we're trying to figure out if somebody's at risk of having alcohol-associated liver disease, we're really trying to quantify, do they meet this threshold where our suspicion for alcohol being a cause of underlying liver disease increases? So as I mentioned, one standard drink is 10 grams of alcohol. So you can see at the top there, one standard drink is a half a pint of beer, 1.5 ounces of spirits, or a small glass of wine, which is typically 5 ounces. But we know that when people use alcohol, they tend to not measure it out. And so when I'm taking a history from somebody, usually I try and understand larger quantities of alcohol and then understand how much is in that given quantity. So for example, on the bottom here, you have a bottle of wine. So a bottle of wine typically contains 8 standard drinks. So if I'm talking to somebody and they tell me that they consume on average 2 bottles of wine per week, then I know that equals 16 standard drinks. And if you average that over 7 days for a female, that would be higher than or that would be within the amount that could put individuals at risk of alcohol-associated liver disease. But one thing that I also want to point out, which relates to potential policy changes related to alcohol, is that there is no requirement for labeling of the quantity of alcohol in beverages in Canada. So this is in stark contrast to our food labeling, where we know how much protein, carbohydrates, and fat are in all of the foods that we eat. But there is actually no requirement for quantification of alcohol, which makes it very difficult for an individual to really try and understand how much alcohol that they are consuming and whether or not that they are at risk. The other important point that I want to make about alcohol-associated liver disease is it's not just the quantity of alcohol consumed which causes alcohol-associated liver disease. There are other patient level and environmental factors that can increase this risk. We know that there are that there's genetic components to this, and such genes such as PNPLA3 have been identified and are associated with a higher risk of alcohol-associated liver disease. We already talked about female sex. We know if individuals have underlying other comorbid liver disease, such as viral hepatitis or metabolic dysfunction associated steatotic liver disease, these individuals can be at higher risk of developing liver-related damage. We know that the type of alcohol and the pattern of alcohol consumption can also increase the risk. So we know that individuals who consume exclusively wine are less likely to develop ALD compared to individuals who consume beer or spirits. We also know that consuming alcohol outside of meal times or binge drinking increases the risk as well. Obesity is also associated with a higher risk, as is the post-bariatric surgery state, and smoking has also been found to be a risk factor for ALD. So what happens in the liver? Why does alcohol actually cause liver damage? So what happens is alcohol consumption leads to increased fatty acid accumulation and deposition in the liver. And this is just a schematic of an hepatocyte or a cell within the liver. And it's just showing you the complicated pathways, but essentially all final calming pathways lead to fatty acid accumulation within the hepatocyte. Once the hepatocytes develop steatosis, then damage occurs in multiple different ways. So the first is by activation of Kupffer cells. So Kupffer cells are the macrophages of the liver, and in response to alcohol byproducts and endotoxins, they can become activated and start secreting anti-inflammatory markers such as TNF-alpha and IL-1. Stellate cells are responsible for the development of fibrosis and scarring in the liver, which also get activated due to these byproducts. And there's also an autoimmune response in the liver, again, causing inflammation and irritation of the liver in the presence of hepatic steatosis. So I'm going to spend a little bit of time on this figure here to talk about the spectrum of alcohol-associated liver disease. So on the left-hand side here, you can see a normal liver, and you can see what happens in the setting of high risk or ongoing alcohol exposure. We talked about these risk factors that increase the risk of developing alcohol-associated liver disease. So typically when we think of alcohol-associated liver disease, there is a slow chronic injury that occurs typically over 10 to 30 years of chronic regular alcohol exposure. And the typical pathway that individuals will move through is they first develop steatosis or fatty acid accumulation within the liver. They then develop steatohepatitis, which means fatty acid accumulation as well as inflammation from the activation of all those Kupffer cells, stellate cells, everything I mentioned in the last slide. And all of this inflammation leads to fibrosis or scarring development in the liver. And once fibrosis develops to a certain degree, we say an individual has cirrhosis. Once you have cirrhosis, you're at risk of developing liver failure. And if this is irreversible, then the only treatment for this is either liver transplantation or death. What I'm going to be talking about later on in this talk is a specific form of alcohol-associated liver disease called alcohol-associated hepatitis. And this is a severe acute injury. So this can occur within months to years of very heavy alcohol exposure, as opposed to above, when regular chronic exposure leads to slow chronic damage. And in contrast to what I described above, when somebody develops alcohol-associated hepatitis, they may go on just to develop fibrosis as a consequence. They could accelerate their progression to developing cirrhosis. And some individuals actually bypass this whole pathway and develop liver failure, even though they do not have underlying cirrhosis. The important thing about alcohol-associated liver disease is that if people are able to maintain alcohol abstinence, the liver has the regenerative capacity to repair itself, unlike many other organs in the body. So among individuals who have alcohol-associated liver disease who are able to achieve alcohol abstinence, recovery can occur over months to years. And this varies by individual and varies based on the type of injury that they've had. But certainly we've seen many, many individuals who have very advanced alcohol-associated liver disease who over time with abstinence are able to recover liver function. This is also true for alcohol-associated hepatitis, and that alcohol abstinence can lead to regeneration and repair of the liver. So when I explain to patients, when I talk about the spectrum of alcohol-associated liver disease, I like to use car analogies. And so I'm just going to walk you through this just to try and solidify these concepts. So when I talk about alcohol-associated hepatic steatosis or fatty acid accumulation in the liver without inflammation, it's like you have a little scratch on the car. There's really no long-term damage. You can easily fix it and the car still works. When somebody develops alcohol-associated steatohepatitis, that's a more severe injury. So that's steatosis in the liver with all of the inflammation that's occurring. So this can be a more severe injury to the liver, but on the same time, it can get fixed with abstinence and the car is still working the whole time. So you're not developing evidence of liver failure. This is how I describe alcohol-associated hepatitis. So alcohol-associated hepatitis is an acute severe injury like a car crash. It can happen with a brand new car that's had no damage, and it can happen with a very old car that's had damage. The key thing with alcohol-associated hepatitis is that it's actually associated with liver dysfunction. And so the car is not working properly. And the question is whether or not the car is fixable. Can we fix it with abstinence and will we regain function? Or do we need to trade it in for a new one? This is in contrast to alcohol-associated cirrhosis. This is the chronic long-term damage that we talked about, where there's a slow development of liver injury and scarring over time. And early in the stages of cirrhosis, the car may still be able to function, but because it's an old car, it's at high risk of breaking down. So ongoing exposure and insult to alcohol eventually will cause the car to break down. Okay. The next section, we are going to talk about the treatment of alcohol-associated liver disease, and you probably will not be surprised based on what I've already told you that the general principle, no matter what type of alcohol-associated liver disease you have, is abstinence. The single most important predictor of long-term outcomes among patients with alcohol-associated liver disease is whether or not long-term abstinence is maintained. But if anybody's ever worked with individuals with underlying alcohol use disorder, this is a very difficult disease to treat. And 1-year relapse rates back into alcohol can be as high as 80%. So if an individual with alcohol-associated liver disease has underlying alcohol use disorder, it's very well established that a combination of using behavioral therapy plus medical therapy leads to best outcomes. The problem is that most studies which have looked at treatment for alcohol use disorder do not include patients who have very advanced liver disease. And therefore, we have very little data to help us understand the outcomes of alcohol use disorder treatment among individuals with advanced alcohol-associated liver disease. There was a population-based study of insured individuals in the United States where they looked at individuals with alcohol-associated cirrhosis who had underlying alcohol use disorder, and less than 15% actually ever received any sort of treatment for AUD. When we do talk about pharmacotherapy for alcohol use disorder, there's several options that we can use. The top is a camprosate, which has, again, not been studied specifically among patients with advanced liver disease, but because of the pharmacokinetics and being renally cleared, it's typically recommended that could be a consideration in patients with advanced ALD. Baclofen has been studied in patients with advanced ALD and did show improvement in abstinence rates compared to placebo. Naltrexone is used very commonly to treat AUD, but it is cleared hepatically. So it's suggested to use this with caution in patients with advanced liver disease. However, recent studies are coming out suggesting that naltrexone is safe and effective in this population. Gabapentin can also be considered, and it's renally cleared. And we do not recommend using disulfiram or antabuse, which many people may have heard of before. And that's because it's cleared hepatically, and there has been many case reports of acute severe liver injury in the setting of disulfiram for alcohol use disorder in patients with alcohol-associated liver disease. Okay, so given that background information, we're now going to move on to some of the work that we have been doing looking at alcohol-associated hepatitis in adolescents and young adults in Ontario. So as I mentioned earlier, there are specific populations within Ontario which are experiencing differential harms from alcohol. During my last talk, I focused on women. There's also some data suggesting rural residing residents as well as Indigenous populations are also experiencing higher harms than would be expected. But for the rest of the talk, I'll be focusing on the harms related to adolescents and young adults. So this was one of the first studies that started to shed light on this problem. So this was data published back in 2019 in CMAJ by Dan Marin and his group in Ottawa, where they looked at emergency room visits secondary to harmful alcohol use between 2003 and 2016. And what they found is that over that period of time, there was a significant increase in emergency department use secondary to the consequences of alcohol. It was higher among women than it was in men. And specifically, emergency room visits due to alcohol increased most among young adults, where it increased by 175%. Similarly, anybody who has been practicing within hepatology over the past decade, we have clinically seen many, many more young individuals presenting to clinic or presenting to the emergency room with alcohol-associated liver disease. This was a study that we published several years ago where we looked at the incidence of alcohol-associated cirrhosis within ICES, and we stratified it based on an individual's birth cohort. We were able to describe the incidence up to 2017 and then projected what will happen over the next 20 years if no changes are made into how we manage this condition. And as you can see by the graph, the individuals in orange and the individuals in the gray are the youngest individuals, and those are the groups of people who are going to be developing alcohol-associated cirrhosis at higher rates. This is compounded by the COVID-19 pandemic. As a clinician, if you have been working during the pandemic, you would have noted in many different facets that alcohol use increased significantly. There's lots of data showing sales of alcohol increased, and there's lots of data also suggesting that the proportion of individuals presenting with alcohol-associated liver disease has increased as well. So because we knew that adolescents and young adults were at high risk and that alcohol-associated hepatitis is the most severe liver-related injury secondary to alcohol, we wanted to look into this further. What we already knew was that hospital admissions for alcohol-associated hepatitis were increasing most among adolescents and young adults aged 13 to 39. And additionally, rates of liver transplantation in the United States for alcohol-associated hepatitis were rising faster in younger individuals than any other age group. There's a lot of information on the outcomes, the short-term outcomes of alcohol-associated hepatitis. There's many studies over the past several decades from all over the world that has looked at short-term mortality or 90-day mortality. And they've stratified that based on whether you have mild or moderate or severe alcohol-associated hepatitis. If you have mild moderate disease, 90-day mortality is less than 10%. But if you have severe alcohol-associated hepatitis, mortality can be as high as 45%. We also know that these individuals respond very well to liver transplantation in select populations. As mentioned earlier, we also recognize sex differences in alcohol-associated hepatitis due to the differences in the susceptibility of hepatic injury to alcohol. And there's also gender differences in alcohol use engagement of alcohol use disorder. So knowing that, there were some things that we didn't know that we wanted to explore further. Although we had a lot of data on the epidemiology of alcohol-associated hepatitis, we did not have any data from Canada, and we did not have any data that was able to stratify to whether or not these individuals had mild, moderate, or severe disease. We also knew very little about the demographics and the social determinants of health of the population suffering from alcohol-associated hepatitis. With respect to outcomes, we knew very little about long-term outcomes after 1 year, and it was unclear what the long-term mortality and liver-related mortality was. It's also unclear who is at risk of developing cirrhosis and decompensation after their first presentation. Further, little information was known about the sex-specific differences in the demographics, natural history, and long-term outcomes of this population. So knowing that, we developed our study objectives. The first one was to define the contemporary epidemiology and demographics of adolescents and young adults with alcohol-associated hepatitis from a diverse population. And we wanted to define the association between sex and long-term mortality and the development of liver-related complications among this group. So in order to do this, we performed a retrospective population-based cohort study using the databases from ICES. And I'm sure that you're all familiar, but one of the strengths of using ICES is that the population is very diverse. There's approximately 14 million individuals covered under OHIP, and 20% of individuals are recent immigrants or refugees. So we identified adolescents and young adults with their first presentation of alcohol-associated hepatitis, either to the emergency room or to the inpatient setting between 2002 and 2021, and we followed them until 2022. And alcohol-associated hepatitis was defined based on an ICD-10 code if it was listed as the primary diagnosis, either to the emergency room or to the inpatient visit. And previous validation studies have suggested that this has a positive predictive value of 90%. We excluded anybody who had a history of cirrhosis or liver-related decompensation at baseline, anyone who had a liver transplant, and of course, anybody who lacked an identifier for us to link to the data sets. Our main exposure that we wanted to look at was the association between sex and our outcomes, which we got from the RPDB. The outcomes of interest were overall mortality, again, which we got from the RPDB, and that was updated to 2022. Cause-specific mortality we got from the ORG database, and that is only updated to the end of 2018. We also wanted to look at the development of cirrhosis with or without decompensation based on our previous validated algorithms. And we looked for liver transplantation based on deceased and live donor billing codes and the Canadian Organ Replacement Registry. Key demographics and covariates that we looked at were underlying comorbidity, which we calculated using the Ellig-Sauer Comorbidity Index. We also wanted to get a sense of how these individuals were using the healthcare system before they presented. So we looked 2 years prior to their initial presentation for any presentations related to alcohol, substance use, or mental health. We identified whether individuals lived urban or rurally, and we had if they were an immigrant or a refugee to Ontario since 1985 by linking to the CIC database. And we looked at several neighborhood level social determinants of health quintiles, including income, ethnic diversity, and housing instability. So for our statistical approach, we wanted to calculate the incidence of alcohol-associated hepatitis in this population and compare rates over the study period using Poisson regression and rate ratios. We then wanted to look at the association between female sex and our outcomes, which we did using multivariate competing risk regression, where the outcomes of overall mortality, liver transplantation was a competing event. And when we wanted to look at the outcomes of cirrhosis with or without decompensation, we used death and transplantation as competing events. So this is the development of our cohort. After our exclusions, we identified 3,340 adolescents and young adults with their very first presentation of alcohol-associated hepatitis with no previous history of cirrhosis or our outcomes. We then went on to calculate the incidence over the study period, and we found that on average, the incidence of alcohol-associated hepatitis in this demographic increased on average by 8% per year. But then we wanted to look to see what was the impact of provincial changes to alcohol policy and how that related to increase in incidence. So our baseline time was between 2002 and 2010, where there was really no changes to governmental alcohol policy. The next era that we looked at was between 2011 and 2015. And this is when the sales of alcohol started to expand to things like movie theaters, bookstores, different places were now allowed to sell alcohol and it could be consumed there. We'll all remember in 2016 when alcohol sales started to occur in grocery stores. And then the COVID-19 pandemic happened in 2019. So you can see up at the top here, the rate ratios with each change in alcohol policy or with the advent of COVID-19, the incidence of acute alcohol-associated hepatitis increased in adolescents and young adults. So next, what we did is we started to look at different subgroups of our cohort. So among those with their first presentation, 74% of them were admitted to hospital, 26% of them were seen in the emergency room and then discharged. We then excluded individuals who developed cirrhosis or decompensation at their very first presentation or who had died during their hospitalization. And we also wanted to give a washout period of approximately 6 months. Interestingly, when we did this, 26% of adolescents and young adults with their very first presentation of alcohol-associated hepatitis actually had underlying cirrhosis at the time they first presented. So once we excluded those individuals, we were left with 2,374 adolescents and young adults who survived 6 months post-discharge from their first episode of alcohol-associated hepatitis and were at risk of developing cirrhosis and related complications during follow-up. So then what we did is we looked at several different outcomes. So we took the entire cohort and looked at long-term mortality. We looked at hospitalization outcomes among those who were hospitalized. And finally, we looked at the development of cirrhosis with or without decompensation among those who survived their first episode without underlying cirrhosis. So these are the demographics of the overall cohort. 36% of them were female, and the median age at presentation was 33 years, and the youngest individuals presenting were 14 years of age. The majority had minimal underlying comorbidities, But within 2 years before their first presentation, the majority had already had emergency room or inpatient stays for the consequences of alcohol. 57% of them had a history of mental illness, and 34% of them had a history of substance misuse. We then looked at the social determinants of health, and we stratified that between males and females. And we can see that these individuals were more likely to live rural, and this was more common among females than males. They typically resided in the lowest income quintile, again, more likely among females than males. However, males were more likely to be recent immigrants or refugees or live in the highest ethnic diversity quintile. Equal proportions between male and females were living in the quintiles with the highest housing instability. So this is a very vulnerable population that we're studying here. So when we looked at hospitalization outcomes, we had over 24 individuals who were hospitalized. The median length of stay was 4 days. And we looked at severity at the top there. So the MELD NA, or the MELD score, that's a score that we use to judge the severity of alcohol-associated hepatitis. 33% of them had severe alcohol-associated hepatitis. We can see that 16% of them went to the ICU. They were seen in consultation by many services, and 2% required dialysis. Now, only 2% of these individuals actually died while in hospital. But when we look to see what happened to these individuals after they were discharged from hospital within 7 days of this very severe acute liver injury, which would need to be followed up, very few of them had any healthcare encounters within 7 days. And if they did, the majority of them were seeing their primary care physicians, as opposed to GI or hepatology specialists, internal medicine, or psychiatry. We next looked at the outcome of overall mortality. So we had over 3,000 individuals who had their first presentation, and we followed these individuals for a median of 5 years. And we also looked at the outcome of liver transplantation. And in this young group of individuals, 25% of them had died within 5 years of their first presentation, and there was an equal proportion of males and females. Of note, very few of these individuals received liver transplantation, and of those who did receive a liver transplant, it was more likely to be males than it was females. We then calculated the cumulative incidence of overall mortality after these adolescents and young adults presented, and we looked over 20 years. And you can see that by 10 years, 31% of females and 29% of males had died after their first presentation of alcohol-associated hepatitis. We then did competing risk regression analysis to look for factors associated with overall mortality. And although the hazard ratio for female sex was high, the confidence interval crossed the null. Other factors associated with mortality in this population were older age, if you were admitted to hospital after your first presentation, if you had underlying cirrhosis or decompensation at the time you presented, if you resided rurally, and if you had higher underlying comorbidity. In the subgroup where we had cause of death available, we looked to see what the causes of death were. And the most common cause of death in this group, maybe not surprisingly, was a liver-related death. But liver-related deaths were more common in females at 28% versus in males at 23%. The second most common cause were external causes such as injury, accidents, poisoning, and suicide, which were more common among males than females. And the third most common cause was mental health disease, which was equal between males and females. We were specifically interested in the liver-related mortality, so we described the cumulative incidence of a liver-related death stratified by sex. And you can see during follow-up, females were more likely to have a liver-related mortality than were males. Finally, we wanted to look and see who was developing cirrhosis with or without decompensation after they survived their first presentation of alcohol-associated hepatitis. So this was 2,374 individuals who had survived at least 6 months without cirrhosis, and we followed them for 4 years. And we looked at the competing events of death as well as liver transplantation. And after a median of 4 years, 31% of these individuals developed cirrhosis, and 30% of these presented with decompensation. And there were more females that developed cirrhosis and decompensation than were males. Again, there was a high risk of death in this population. 20% of these individuals actually died during follow-up, And again, very few received liver transplantation. When we calculated the cumulative incidence and we stratified it by sex, you can see that at any point in time, women were more likely to develop cirrhosis or decompensation compared to men. And importantly, most of the development of these complications occurred within the first 5 years after their presentation of alcohol-associated hepatitis. When we did adjusted competing risk analysis to look at the association between these factors and the development of cirrhosis, female sex was associated with a 47% higher hazard of developing liver-related outcomes compared to males. Other factors were older age, urban residence, and having higher comorbidity. So the summary of the results from this study were that the incidence of alcohol-associated hepatitis is rising among adolescents and young adults, with death occurring in 25% after a median of 5 years of follow-up. And this young alcohol-associated hepatitis population is vulnerable in their social determinants of health, and sex differences and underlying sociodemographic factors are present. And although overall mortality after a first presentation of alcohol-associated hepatitis is similar between the sexes, females have higher rates of liver-related mortality than do males, and female sex is associated with almost 50% higher risk of cirrhosis and decompensation among those who survived their first alcohol-associated hepatitis presentation. And so really, I think the implications of this data is this should really be considered a public health crisis. These are individuals under the age of 40 years old, where 25% of them are dying within 5 years of their first presentation, and we're not doing anything about it. And unless efforts for early identification of alcohol use disorder and ALD in this population is prioritized, there will be considerable ongoing premature mortality in this young, vulnerable population. And efforts in order to reverse these trends will really require a sex-specific approach, as I've shown you that the demographics and the outcomes differ based on whether an individual is male or female. So finally, I want to end with talking about some of the other health policy implications of the current situation of alcohol-associated liver disease in our population. And whenever we approach from a public health perspective, we can talk about primary, secondary, and tertiary prevention. So primary prevention is limiting the exposure of alcohol to our population. Secondary prevention is the early identification and treatment of heavy drinking, alcohol use disorder, and alcohol-associated liver disease, whereas tertiary prevention is the treatment of end-stage liver disease from alcohol. So when we look at issues related to primary prevention, there's many things that could be done. From a governmental policy perspective, we know from other countries that minimum unit pricing of alcohol can have significant impact on the amount of alcohol consumed within a population. We know that there's targeted marketing, especially to adolescents and young adults, with very little oversight by the government. And I've already talked about the lack of labeling to quantify alcohol on products sold in Canada. I've shown you that the social determinants of health are associated with alcohol-associated liver disease, and so public health efforts to improve these would likely result in improvements. We need to educate the public as well as other individuals suffering from these conditions about alcohol-associated liver disease. I didn't talk much about Canada's low-risk drinking guidelines, but I'm sure that you're all aware that these were recently changed and that any more than 2 drinks per day, regardless of if you're a male or a female, is recommended for Canadians. And as highlighted with some of the data, access to mental health treatment is essential, and it will be essential for any of these preventive efforts. When we talk about secondary prevention, we talked about the need for alcohol use disorder trials that use a sex and gender approach, as well as be inclusive of individuals with advanced alcohol-associated liver disease. We need to have strategies to screen for alcohol use disorder and ALD at the level of primary care so we can identify individuals early before they develop complications. And we need to really promote combined hepatology and addictions clinics where we can manage both the alcohol-associated liver disease as well as the AUD at the same time. When we're talking about tertiary prevention, this is really related to equal access for transplantation for individuals with alcohol-associated liver disease. This is a whole other talk, but I could go into a lot of details about how the policies regarding alcohol-associated liver disease and transplantation have changed over the past decade. We talked already about combination hepatology addiction clinics, and we really need to have trials in this population that use a sex and gender approach. And as mentioned, access to mental health treatment is essential. I'm going to end with just pointing you to this opinion piece that I wrote recently with one of our GI trainees. about the different aspects that we need to consider when addressing disparities in alcohol use disorder treatment in individuals with alcohol-associated liver disease. From a provider perspective, we need to be better at using tools to screen for alcohol use disorder in our clinics. And we need to educate hepatology providers who are seeing these patients about alcohol use disorder treatment. As I showed you, less than 15% of these people ever get treated for their alcohol use disorder. From a hospital level, we need to be able to provide access to language and transportation services for alcohol use disorder behavioral therapy. And we need to have timely and equitable access to addiction medicine, social work, and psychiatry, which is very, very difficult to get right now in our current healthcare situation. From a research agenda, we need to design high-quality studies that evaluate alcohol use disorder treatment in individuals with alcohol-associated liver disease. And we need to prioritize the inclusion of study participants who are diverse in age, sex, race, gender, as well as culture. And finally, from a societal perspective, we really need to reduce the stigma associated with alcohol use disorder and ALD so people feel comfortable presenting for help and know where to go and seek it. And public education on alcohol use disorder and the outcomes of treatment need to be more widely known. So in conclusion, alcohol-associated liver disease is a significant health threat, especially to our adolescents and young adults. And this group of individuals with the most severe form of alcohol-associated liver disease are at high risk of dying or developing cirrhosis within 5 years after their first presentation. And really, we're going to need efforts from governmental policy as well as public health interventions to be developed in order to reverse these trends for future generations. And if that, I would like to thank you for your attention. I would like to thank all my people at ICS, with a special shout out to Maya, who did all of the work on our ICS projects, as well as HISPRI, and then the funders of this work. So with that, I will stop sharing my screen, and I'm happy to take questions.
Hi, Jen. I've got a question for you.
Sure.
Yeah. First of all, thanks. That's a very in-depth and wonderfully presented presentation. It's very informative, and I learned quite a bit. I was thinking back to your slide about primary prevention, and I was just wondering, in your opinion, what are the biggest barriers to actually implementing any of those?
I mean, I think based on what we know from other countries, and we're talking about governmental policy, that those are the big things from a primary prevention that are effective. So minimal alcohol pricing, dealing with marketing, labeling, all of those things. And we know that the way that alcohol is distributed within Canada is that it's regulated by the government, and they also get monetary benefit from the sales of alcohol. So it's a very, very tricky situation. And you also know how difficult it is to do any sort of governmental lobbying. The other problem with alcohol use is that because the population most affected are vulnerable in many aspects of social determinants of health, they are not advocates for themselves. And so there's not a big advocacy group for this condition, as opposed to other conditions that where there's lots of patient advocacy. So I think all of those things make it very difficult for change to happen quickly. Thanks, Jonas.
Thank you, Jen.
There was a question in the chat from Joy.
Okay, I'll take a look at that. Thanks, Joy. So some individuals saw their family doctor after discharge. This cohort fare any differently than those who had no follow-up within the week? Thanks for that question. That's kind of the next step that we want to do. We want to look at how these individuals are utilizing the healthcare system to figure out where best we need to deploy strategies. And we also want to look at the proportion of individuals who did engage in alcohol use disorder treatment to look to see if their outcomes are better. One would expect that they would be. But I think what the data is suggesting is that primary care is going to be essential in order for us to try and tackle this. because a lot of individuals are utilizing primary care as opposed to specialty services after they're presenting. But I hope to update you next time when we get a chance to look at that data in a little bit more depth. Anybody else? Any other comments? Anybody with any experience dealing with this population and having struggles with them?
I'm just interested to see the updated results following the further relaxing of alcohol policy in Ontario.
Right. Yeah, I didn't mention that, but thanks for reminding me, Sherry. So for those of you who aren't aware, there was a news release back in December that by January 1st, 2026, that alcohol sales will now be expanded to convenience stores. And so now you're going to be able to go to any store, any corner store, and purchase alcohol. And we can see, based on the trends of what's happened so far, I would obviously anticipate that this is just going to continue to get worse. Now, part of the issue with our data is this is just circumstantial. Like, I can't necessarily say that this alcohol policy resulted in this, but the trends kind of, I think, speak for themselves. Okay, well, if there are no further questions, I want to thank everybody again for their attention. And please reach out to me if you have any comments, questions, anything you want to talk about offline. I always like hearing from other people. So thanks again, everybody.